Good afternoon, everyone, and welcome to the 14th episode of the Medical Education Clinical Reasoning Program. We hope that you had a relaxing weekend and that you're ready for our episode today. We're very delighted to welcome you to this special episode that we have in collaboration with the Association of Women Surgeons. For the first time, the Medical Education Clinical Reasoning Program is presenting a surgical case. We hope you enjoyed and benefit from this unique spin-off. As usual, let us start by introducing today's panelists. From SKMC, we have our clinical advisor, Dr. Hisham. Our resident for today is Dr. Fatma, and our two case discussants are Mariam Hussein and Mariam Al-Filasi. We will give our panelists the chance to briefly introduce themselves, and then we will start our episode. We can start with you, Dr. Hisham.
Thank you very much for inviting me for this interesting session. I am very delighted to be part of the panel. My name is Hisham Horais. I'm an upper GI general and laparoscopic surgeon at SKMC, and I am the site coordinator for final year medical students from UAE as well. And I have great interest in medical education and surgical education. I've been doing that for the last maybe 15, 20 years. I wish you a very successful seminar and very useful seminar, inshallah.
Assalamu alaikum. My name is Dr. Fatma Harmoudi. I'm a general surgery resident from Tuam Hospital.
Hi everyone, I'm Mariam Al-Filasi. I'm a fifth year medical student and I'll be one of the discussants today.
Good afternoon, everyone. I'm Mariam Hussein. I'm a senior medical student at the United Arab Emirates University, and I'll be one of the case discussants today.
Thank you all for this introduction. We're very honored to have you all with us today. I would like to use this opportunity to remind our audience to leave their questions and comments in the chat box for us to address them later on. With this, I will give the mic to Dr. Fatma to present for us today's case. Dr. Fatma, the floor is yours. Dr. Fatma, you can start with the case.
Okay. So we have one patient that was admitted to our hospital. She is a 27 years old female, presented with worsening upper abdominal pain for 3 days. I will try to do this session as with the students. So I just want to know if you have this patient that presented with abdominal pain, what questions you would be asking this patient?
We would ask about the onset of the pain,
Okay.
and we would ask about the location of the pain, the duration of the pain, is it continuous or worsening in nature, what is the character of the pain, anything that aggravates or relieves the pain, and about the severity of the pain.
Okay, what else?
I was going to say the radiation of the pain or if it changes with position.
Okay.
Go ahead, Mariam.
If it's associated or it's painful more with food intake or any specific movements that would relieve or exacerbate the pain.
Okay. What else? You'll be asking the patient if this is also the first time that this pain presented or not. If it doesn't, if she had this pain before, what type of things she did? Did she seek any medical advice or not? What medication she did? And what was the onset of the pain? Was it a very similar attack or not as well? Okay. So for this patient, she presented, she's a healthy woman, presented to the ER with worsening upper abdominal pain for 3 days. The maximum point of the pain was in the epigastric region. The pain radiates to the back, and the pain is recurrent and episodic. The first episode that the pain was started was 3 months ago. The duration of the pain was an hour on an average. In the current attack, the pain was continuous and worsening for the 3 days. The characteristic of this pain was colicky. The relieving factors was leaning forward, and the aggravating factor was eating fatty meals. This patient had the previous encounter in the clinic 3 months ago with similar symptoms. She was given PPI and Panadol with no relief in symptoms. She tried ginger and lemon water with no relief, no specific timing for the pain, and the severity was 8 out of 10. After knowing this history from this patient, what else you will be asking this patient? What are the associated symptoms?
Vomiting, diarrhea, constipation, nausea, and we would also ask them generally if they have got any fever, any change in weight.
Okay. What else? So when you are going to take a history from the patient, just think whatever the differential diagnosis you are having so that you can rule it in or rule it out. So your questions will be targeted towards whatever differential diagnosis you will be having. So what's your differential diagnosis from what you are getting from this history at the moment?
Cholecystitis.
Okay.
Pancreatitis.
Okay.
Peptic ulcer disease.
Okay.
It could be gastritis.
Okay.
It could be also early signs of appendicitis.
Okay. Could be also something in the chest as well, right?
MI.
Yes.
What
Okay.
about the lungs?
Also pericarditis.
Lower lobe pneumonia.
Yeah.
Okay, so the patient had loss of appetite, nausea, vomiting, and constipation. She denies fevers or chills, itching, or yellowish discoloration, which is very important if you are going to think about something in the gallbladder like a stone or cholecystitis or whatever. And also you'll be asking about the color of the stool as well and the urine. She denies any diarrhea and stool changes. She denies any blood or mucus in the stool. She denies any signs of urinary infection, and there is also no blood in the urine or anything like this. She's denying any chest pain or palpitation, no cough or shortness of breath, or any flu-like symptoms. Denies any prior use of also antibiotic, which is also very important because if the patient is taking antibiotic, it will decrease the infection, and she will not be presented typically with signs of infection like fever, tachycardia, and those kind of stuff. She has the loss of appetite, which started 3 months ago, and it was continuous. She vomited once 2 days ago. The content of the vomitus was food, and the color was yellow. There is no blood or specific smell. The pain started first, followed by vomiting. Constipation started 3 days ago as she passed the stool once, and the stool was hard in nature. There was no changes in the color. Also, since we know that this patient had already a previous attack of the same problem, as we mentioned, we should ask the patient if she sought any medical advice or not. So, for example, if she did the previous ultrasound or not, if she did any endoscopy or not. This will help us to rule out even ulcers, peptic ulcers. And what treatment she was given. We know that at the moment she's not on any antibiotic. After finishing from all of this, what are the review of the systems that we need to ask her?
So we'd ask her about covering the musculoskeletal system and neurological system, about generalized fatigue, muscular weakness, coordination, and sensation. And we would also cover other constitutional symptoms like the skin rashes and weight changes and any headache.
Okay. We'll be also asking her about her last menstrual period since she's already 27 years old female. Okay. And the other things that we mentioned as well, that she had loss of appetite, so she might have lost weight. So we need to know how much she lost and for how many months or days she has lost it. So her last menstrual period started 3 days ago, lasted for 1 day. It is a regular menses, no pain during the menses or any changes in amount of presence of the clots. The menses occurs every 23 days and lasts for 7 days. So later on, we'll be asking her also about the past medical and surgical history or any previous traumas or anything. So she denies any past medical condition and she denies any surgical or hospital admission, no trauma or any other injuries. She's not taking any medication and she is not having any allergies. She doesn't have any family issue or any family problem in her past family history as well. So why it is very important to ask the past medical and surgical history with also the past family history.
What
So
conditions can you think about that might be familial or have a familial tendency?
Hypercholesterolemia.
Okay.
Autoimmune diseases,
Okay.
cystic fibrosis.
Okay, yeah, that's in general. Let's just think surgical. Very simple, very... So gallbladder disease tends to run in families. There's a familial association. It's not a familial disease. It's not a genetic problem, but family history of gallbladder disease or gallstones makes the patient more predisposed to getting gallstones. So family history of gallstones, weight loss, as we mentioned before, sudden rapid weight loss, female gender, the four F's as we know them, but family history, there is a strong association between a family history of gallbladder disease and having the disease. So that's one thing. What else?
She had prior surgeries like cholecystectomy, so we can exclude that the cause it's cholecystitis. It could be like a common bile stone instead.
Primary ductal stone, that's right, yeah. And family history, you have to remember there are a few familial cancers. There are a few cancer genes that run in family. This lady is 27. Familial polyposis coli has a very high incidence of colorectal cancer. and Lynch syndrome and the hereditary cancer genes for gastric cancer and things like that. This is just if you want to broaden your scope. So I'll let Fatma carry on, and then we will go back and digest the history in detail.
Okay. So also one of the important disease that the patient might be also presenting with stones in the gallbladder is also hemolytic disease. So we'll be asking about like G6PD, thalassemia, and all of these stuff, because even the stones will be a pigmented stone because of this. And as one of you mentioned already, because of the weight loss, we need also to ask about previous surgery. So nowadays we are having a lot of bariatric surgeries like sleeves and bypasses, and the patient, because of the sudden drop of the weight, patient will be having more risk to develop gallbladder stones. Especially that because of the fasting, the gallbladder will have stasis, and the cholesterol in it as well will be increasing in the salt in the stone. So hence the bariatric surgery or any patient that is dieting will have higher risk of developing a gallstone. The other thing is that regarding the medication, it's very important to ask if the patient is taking any medication, especially that some medication can cause gallbladder stones, and the other can cause also pancreatitis. So which both of them are one of the differential diagnoses that we are having in our patient. The other thing is that we need to ask about hormonal medication, especially that this patient is a female. Hence, also we are asking her about her menstrual period and if it is regular or not. Okay. So we finished already our history taken from the patient, and we are going now for the examination. So the patient is conscious and alert without any distress. She is vitally stable, afebrile. Head and neck examination were unremarkable. She doesn't have any signs of icterus or any jaundice. Abdominal examination is normal, abdominal contour. Midline umbilicus and inverted umbilicus, no scars, no hernia, no visible organomegaly or any discoloration or any devices in her abdomen. Auscultation of the abdomen, sounds were present, and there was no bruit. Percussion, the patient had a tympanic sound over the stomach and intestine, and muffled sounds over the liver and the spleen. Bladder is not distended, and the liver span was 8 centimeters. Superficial palpation showed that the patient is having soft abdomen, tenderness over the upper quadrant, and increasing the tenderness in the epigastric region. No masses felt or any pulsation felt. In the deep palpation, no guarding tenderness over the upper quadrant, right upper quadrant. Increasing tenderness as well, with no rebound tenderness, no masses felt as well. The liver is palpable below the costal margin area, soft and smooth, non-tender. And the palpation of the spleen was unremarkable, and no lymph node in the inguinal region. And the patient was having negative Murphy's sign. So from the history and the physical examination, what's your differential diagnosis at the moment? Did we manage to rule something out from the previous discussion?
So I guess the negative Murphy signs can partially rule out cholecystitis.
Okay.
And since there is tenderness over the right upper quadrant, we can think also of hepatitis maybe as a differential.
Mm-hmm.
Can I just mention one thing? Murphy's sign is not a very sensitive. It's not. How often do you see patients with cholecystitis with a Murphy sign? You rarely see Murphy's sign, and it's a very difficult sign to elicit as well. So if Murphy's sign is negative, I would not rule out acute cholecystitis, to be honest.
Especially if sometimes done wrongly.
Yeah. It's not one of the things that are pathognomonic of cholecystitis. As Fatima said, this from the history, the history is very, very detailed. And we started with upper abdominal pain, and this is a clinical reasoning session. So we started with almost everything that can cause pain in the upper abdomen. And we mentioned that the pain is episodic, severe, precipitated by fatty food. We talked about urinary symptoms to see if there's any relation to the urinary tract. We talked in detail about her gynecological history to rule out any gynecological causes. We did talk about her bowel symptoms, and we said that she's constipated, and we said that she has been vomiting. And we talked about chest symptoms as well: cough, shortness of breath, cardiac problems or cardiac symptoms, in order to try and come up with a vague general idea about what this could be. So, and then one of the things that might cause a bit of confusion is the fact that she vomited and she had constipation and the pain was colicky. So that brings in another dimension to the problem. But when you come to the examination, her abdomen was not distended. She has normal bowel sounds and no previous scars and no palpable masses. So that narrows the differential diagnosis. So with all these factors in mind, what organs or what diseases are we thinking of?
So we're ruling out mostly the cardiac and respiratory causes.
Okay.
So we can focus more on the GI and like liver or the gallbladder and pancreas.
Okay, yeah. So hepatobiliary problems, more or less. And we still can say that we have not ruled out the GI, as in bowel, small and large bowel, completely. Am I right?
Yes.
Okay.
Okay, so the next thing that we are going to do to confirm one of our differential diagnosis is to do investigation. So what are the labs that we are going to order to rule it out or rule it in?
Or lab tests that are important in the management of this patient. You have to remember this is an acutely ill patient who presents to the hospital with an acute problem now. She was seen in clinic, but she is now having an acute problem. So anything that will help in either reaching a diagnosis or managing this patient. What are the blood tests that you're going to be thinking of?
CBC with differential to check for the signs of infection, including white blood cells, or if there is any loss of blood, like anemia, determining hemolysis. And we can check the inflammatory markers, although not specific. So we can check the C-reactive protein. We can do the liver function test because we're thinking about hepatitis and cholecystitis. And we can do renal function tests in terms of giving medications. So we need to know if the renal function test. And we can do ultrasound as well, abdominal ultrasound.
Okay, there is also another important test.
The amylase and lipase.
Yes. So we are going to also order an amylase and lipase because we are focusing as well on the gallbladder and the complications that can have from the gallbladder stone. Okay. Also, since the patient is female, we are also going to order also beta-HCG. We will check also, although that the patient insisted that she doesn't have any medical problem, we'll just also check her glucose random, because sometimes we can have early diagnosed diabetes in the ER, which can also present it as epigastric pain. We'll check also the urine analysis for this patient as well. And as you said, also we'll do an ultrasound abdomen for the patient. We mentioned also a peptic ulcer disease, so it's very important to do as well a chest X-ray and also an abdominal X-ray to check for air under diaphragm. Okay, and since we already discussed previously about pigmented stone, some of the stones in the gallbladder also can present in the abdominal X-ray. Okay. So the results of the labs, beta HCG was negative, CBC was showing leukocytosis, AC and ALT were elevated, creatinine and urea were high slightly, amylase and lipase are elevated 3 times above the normal level, glucose random is normal, bilirubin total and direct and alkaline phosphatase also were elevated, urine analysis was unremarkable and the X-ray was unremarkable. The ultrasound was done and it was showing cholelithiasis. CBD was measuring around 0.4 and there was no pericholecystic fluid or radiological Murphy's sign. So what's our final diagnosis now?
So since the amylase and lipase are 3 times above the normal level and we've got the raise in the liver function test, we can think of acute pancreatitis that is caused by stones.
Okay, so it is called what? Biliary pancreatitis, right?
Yes.
Okay, because pancreatitis alone has already other differential diagnoses. So from our side here, we have proven that the patient is having gallstones and the pancreatitis is most likely because of the gallstone. Okay.
You can even specify more, saying that it's gallstone pancreatitis, because biliary pancreatitis does involve some other rare causes like malformations of the biliary tract.
Mm-hmm.
These can cause pancreatitis as well. But I think you're right, Fatma. You have to specify that this is pancreatitis with a known cause rather than an unknown cause.
Mm-hmm.
So the likelihood that this is secondary to something other than gallstones is very, very low. You have an ultrasound, and when you're asking for an ultrasound, you exactly pinpointed it. You want the sonographer to tell you if the gallbladder is distended or not, does it contain stones, sludge or not, is the wall thickened or not, is there any pericholecystic fluid indicating cholecystitis or not, and is the CBD dilated? And what's the CBD diameter if possible? And if there is a stone, can they see that stone? So you've mentioned all that. This is very important information. And you have to remember, in gallbladder disease, ultrasound is of paramount importance. CT will not tell you any of these, probably tell you if there is cholecystitis or not, but it's likely to miss most of these. And generally in abdominal pain, the way we go, the radiological step ladder for investigating abdominal pain is just as mentioned earlier. You start with an erect chest X-ray and a plain abdominal X-ray, looking for free air in the diaphragm and calcified stones, which is not very common to see. Roughly about 10% of gallbladder stones can be seen on plain films. And then you move on to the next simplest non-invasive investigation, which is ultrasound, then CT scan, and then you move on to more sophisticated stuff. So we assume that this is gallstone pancreatitis.
So even from the ultrasound finding, sometimes as we were saying that Murphy sign is not even sensitive that much to rule out or to rule in acute cholecystitis. But if the patient is having positive Murphy, but the ultrasound is not showing signs of pericholecystic fluid or gallbladder wall thickening, we still believe that this might be an early cholecystitis and the patient will be taking antibiotic. So for this case, this is a biliary pancreatitis. The patient will be admitted. We're not going to start her on any antibiotic because clinically and even radiologically, the patient doesn't have any signs of cholecystitis. So we'll be starting her on the treatment of pancreatitis, which is IV hydration, and following this up with laparoscopic cholecystectomy later on, once the pancreatitis resolves. If the patient will be having increasing CBD, at that time we'll be discussing this case with the GI for either MRCP or ERCP to be done for this patient.
So for this exact lady, this same case, if I can ask the students, what's your next step? So you have slightly drained LFTs, you have evidence of pancreatitis and gallstones, and the patient landed in your unit. So halas, we have an ultrasound, we have come to the diagnosis of acute cholecystitis secondary to gallstones. What's your next step? If you're going to, so you're managing this patient as an acute pancreatitis with pain relief, IV fluids. We said we will not, if you're going to give her antibiotics, you have to have a reason. We don't have a reason. Will you allow her to eat or drink?
No, she has to stay on PO.
Why?
Because basically it aggravates the symptoms, and also she'll probably be going to surgery soon.
Okay, so how long are you going to keep her fasting for? So everything that you mentioned has to be for a reason. So you want to keep her fasting because you might do surgery on her. And if you're not going to do surgery, can she eat?
No.
Why?
I mean, it will aggravate her symptoms, but I'm not sure if there's any other reason.
Okay, well, that's in the first 24 hours, I would agree, probably keep her fasting. But after that, there's no evidence that fasting affects the outcome of pancreatitis. If anything, early introduction of enteral feeding reduces the risk of septic complications in patients with pancreatitis. So, so what's the next step then? So she had some fluids, you've corrected her electrolytes, she was a bit dehydrated, you've corrected her electrolytes, and you know the diagnosis. So what's the next step then? Remember, her AST and ALT and ALK phos are all elevated. Although her bilirubin is borderline, but the rest are mildly elevated. We have to think about definitive management. And everything you say, I'm going to ask you why.
Do we schedule her for laparoscopic cholecystectomy?
Okay. So why are the LFTs marginally elevated? So what's the pathophysiology of pancreatitis in gallstones? You have to understand why patients with gallstones develop pancreatitis to be able to formulate a plan for her management.
The stasis of the gallbladder basically causes inflammation of the duct.
So what happens exactly is you get a small stone, and this is what we tell the patients most of the time. If you have one single big stone, you're in a less risk of developing pancreatitis than somebody who's got multiple small stones or sludge, because these small stones, they travel down the cystic duct into the common bile duct and they get impacted in the ampulla of Vater. That causes obstruction of the biliary tract and back pressure on the biliary ducts, and also back pressure on the pancreatic duct, main pancreatic duct. This back pressure leads to leakage of pancreatic enzymes out of the ducts and into the pancreatic tissue. I wish I had a diagram to show you this. And that causes autodigestion. So the pancreas, with its own enzymes, exocrine enzymes, it starts to damage its own tissues. Very powerful enzymes, they leak into the pancreatic tissue, and they cause autodigestion. Okay, so most of these stones eventually pass. They pass without needing anything done. But how do we know that they have passed? Because if they don't pass, they will continue to damage the pancreas. And eventually the patient will develop jaundice and can develop infection into the biliary tract and ascending cholangitis. So how do we know that this stone has passed?
The pain subsides, and it can be also shown in the ultrasound.
Ultrasound is not very sensitive to look at the common bile duct, because the common bile duct and the pancreas are quite behind. They're usually covered by small bowel and large bowel.
Do we do an MRCP?
Exactly. You do an MRCP, there are simple things. As you say, the patient improves, the LFTs go back to normal, and the symptoms start to subside. This is an indicator. If the patient becomes jaundice and the LFTs get worse, it means that there's still blockage, or the stone has not passed. But the objective evidence is to do a more sensitive test to make sure that the CBD has cleared. So, which is the MRCP. Assume that this patient has had a clipping of an aneurysm in the past. She has metal in her body, or a valve, or for logistic reasons. Now, a lot of people, I mean, even in SKMC, in LAM before, in a few centers, there are very proactive gastroenterologists. They say, well, I have a list today. I don't want to wait for the MRCP until tomorrow. So what can you do? So what you can do is you can do what's called an EUS, endoscopic ultrasound, which is very sensitive for CBD stones and biliary pathology in general. So the gastroenterologist will take the patient, will do a scope, and they check with a scope that has an ultrasound probe at the end of the scope. They check the CBD. If there are stones in the CBD in the same setting, in the same session, the patient doesn't need to come back to the ward. They will do an ERCP and clear the stones. Okay? So what's
Yes.
our next step? I'll hand you back to Fatma.
Okay. Before that, you mentioned a very important thing, which is the cause of the pancreatitis usually is very small stones. So that's why we're telling the patients usually that the smaller the stone is, the more dangerous it is going to be on him than the big ones, because the smaller ones are the ones who are causing the pancreatitis. So for these patients, as we were mentioning from the beginning, for cholecystitis, we're going to treat the patient as antibiotic, and later on we are going to operate on this patient. Depends on when exactly the symptoms has started. So if it got started within the same week, we're going to operate on this patient on the same admission. Otherwise, if it is started chronically from before 1 week, we can do the laparoscopic cholecystectomy later on at around 4 to 6 weeks after the presenting of the symptoms.
But there is one thing you have to remember. The guidelines are very clear in this. Any patient who presents with biliary pancreatitis or gallstone pancreatitis, they should, they need to have their gallbladder removed within the index admission or within 2 weeks of discharge. And can I ask the students why? We'll come to the cholecystitis. So why do we need to do that in patients with gallstone pancreatitis?
Because it can carry complications of perforation or more severe complications in these patients. And
more importantly, it's for source control, because even if the stone passes, they are at a higher risk of developing further attacks of pancreatitis. And multiple audits were done to verify this. In the UK, where the waiting lists are quite long and services stretched, patients get discharged with after gallstone pancreatitis, and multiple audits have shown results of 40, 30, 60% of these patients coming back with another attack, which can be fatal as well. So acute severe pancreatitis has a mortality of up to 20%. So you can imagine a 27-year-old carrying a risk of mortality of 20% if she develops an attack of severe acute pancreatitis. So that's the main reason. With regards to acute cholecystitis, the traditional training and teaching was that an acute attack within 7 to 10, up to 2 weeks, can be treated with an emergency cholecystectomy or an emergent cholecystectomy. Anything more than 10 days, you treat them with antibiotics and discharge them and do the cholecystectomy in 6 to 8 weeks. The most recent evidence now is that there is no an urgent or emergent cholecystectomy, even beyond 2 weeks, does not carry any more risks than interval cholecystectomy. So regardless of the duration of symptoms, it will be a more difficult procedure, but there is no evidence that it carries more risk than a delayed procedure.
And it's usually depends on also the surgeon preference as well, if they want to delay it or not as well. But as Dr. Hisham was saying, the risks are almost the same. Although we used to say that there will be a higher chance of a bleeding and complications during the surgery if it is done before the 6 to 8 weeks. So at the moment, as we said, regarding the CBD, if we have dilatation in the CBD or raising LFTs, including the bilirubin and the total bilirubin, and the ultrasound didn't mention anything regarding the stones in the CBD. We will be discussing this case with the GI team for either MRCP or ERCP. So we usually do the MRCP first. If it proves that there is a stone in the CBD duct, then the GI team will be doing an ERCP for the patient. Sometimes they do ERCP as a diagnostic and therapeutic at the same time. If they are thinking that there might be a stone in the CBD, or the patient is acting septic, meaning cholangitis, as one of our differential diagnoses. So they will be doing the ERCP to extract the stone, and they will be doing a sphincterotomy. After ERCP, we know that one of the complications from ERCP is ERCP pancreatitis. So post ERCP will be checking also again the amylase and lipase. But make sure that you don't check it regularly, the amylase and lipase, because at the end the level of the amylase and lipase is not like an indicator of a better pancreatitis or worsening pancreatitis. But we're checking it usually after the ERCP because of ERCP complication. So if the amylase and lipase before were normal, but after the ERCP is high, we'll just keep the patient under dehydration, and we'll do the lab chole for them once the pancreatitis status is getting better and the LFTs are improving as well.
So for amylase and lipase check, if you can ask the students, if you have a patient who's had an ERCP and you check the amylase and the amylase is high, what does that indicate?
Injury to the pancreatic duct?
Not necessarily, no, not necessarily injury to the pancreatic duct. You just need to keep an eye on that patient, because this patient the next day might develop epigastric pain, and then this is pancreatitis secondary. One of the causes of pancreatitis is instrumentation of the biliary ducts or biliary tract, and this is a complication of ERCP. Most of these patients, fortunately, they develop hyperamylasemia without pain. So that is just, you have just annoyed the pancreas a bit during the procedure, but you have not caused severe pancreatitis. And if they don't develop pain, then you're fine. You just let them eat and drink and they go home. if the next day they develop pain with a high amylase, because you have to remember, acute pancreatitis is a disease characterized by acute severe pain with high high enzymes. So the presence of high enzymes without abdominal pain does not signify acute pancreatitis. The other thing I wanted to mention, what are your options for this patient? So you've done an MRCP or followed by an ERCP. In rare cases, as Dr. Fatma says, you do an ERCP straight away because you know that the patient needs an intervention. And we mentioned about the patient who needed an EUS before the ERCP. Let's say that this patient, the LFTs improve the next day, and you have a list, and you can take the gallbladder out. What are your options? Is there a straight surgical option for this patient? Or you're not very good friends with your gastroenterologist? You annoyed them and they don't want to help you, unfortunately.
Maybe if the pancreatitis was severe, you shouldn't do, doing the
Yeah, okay. Well, if the pancreatitis is severe, it's probably advisable to wait until the patient settles. But let's say the pancreatitis, the patient is feeling much better.
Yeah,
And you have a list. What can you do about the clearing the ducts? So a simple thing that you can do is take your patient to theater for a lap chole and do what's called an untable cholangiogram. Inject a dye through the cystic duct and take some photos to see if there's a stone in the bile duct or not. Okay? If there's no stone, you just carry on, take the gallbladder out, and you've sorted the patient's problem. If you find a stone in the bile duct, then you have two options. You either carry on with the cholecystectomy and ask the gastroenterologist to do an ERCP whenever they get a chance, and that's your patient sorted. Or if the stone is big, clear, or multiple, and you have a dilated common bile duct and you have the equipment and the skills, you can do a laparoscopic common bile duct exploration. So you open the bile duct during the procedure, you clear the bile duct with what's called the choledocoscope, and you close it back again. These are all options. So you have multiple options, okay? Another question I wanted to ask you, if somebody comes to your clinic with just biliary colic, what are the chances that they will have a stone in their bile duct, even if their LFTs are normal? Small stone in their bile duct. Do you know? So between 15 to 18% of patients presenting with biliary colic or gallstones would have a stone, an unrecognized stone in their bile duct. But fortunately enough, most of these stones will pass without any intervention. So I think we've exhausted this. I'll leave it for Fatima to conclude if there's any conclusions, and I'll leave it for the students to have if they have any comments or anything to say.
Thank you all for this informative and insightful discussion. We will give the chance to our attendees to share their questions and comments in the chat box. Of course, our discussants can also share their comments or any questions they have. Okay, it seems that we don't have any questions currently. I think it was a very comprehensive discussion, but I just want to remind our audience that they can share their questions with us through our social media accounts, and we'll make sure to share them with both Dr. Hisham and Dr. Fatma. So with that, we will conclude our session. I would like to thank our panelists today for this amazing discussion. We are very grateful and we hope you enjoyed this experience with us today. Thank you, Dr. Hisham, Dr. Fatma, Maryam, and Miriam. It was a pleasure having you all with us today. I would like to also extend our thanks to the Association of Women Surgeons for their cooperation and support, which all made this episode possible. Many thanks for our attendees, and we hope we meet you all in the future in another episode. Thank you all and have a nice day.
Thank you very much.
Thank you.